السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. Our presentation addressed to be carcinoma of thyroid, and we are group one. And this is my colleagues' names, and I am Zaid Ibrahim Al Kharhan. Our presentation is case presentation. A 36-year-old woman comes to the physician because of the painless lump of her neck for 3 months that has increased in size. She appears healthy. Examination show a 2.5 centimeter firm and regular swelling on the left side of the neck that moves with the swallowing. There is painless cervical lymphadenopathy. Ultrasound of the neck show a solitary left lobe thyroid mass with increased vascularity and hyper echogenic puncture region. A fine needle aspiration biopsy is done. Key point in this case scenario: painless lump on her neck for 3 months, swelling on the left side of the neck that moves with swelling, painless cervical lymphadenopathy. Differential diagnosis: may thyroiditis, neck infection or abscess, papillary thyroid carcinoma, thyroid abscess, papillary adenoma, follicular adenoma, may follicular thyroid carcinoma, medullary thyroid carcinoma, and lymphoma. Initial evaluation of patient with thyroid nodule. We can initially start with the TSH level, and if hypofunction, so we will go with a radionuclide thyroid scan. If hot, so let's go with functioning. So that treat this function hyperthyroidism. But if non-functioning or the TSH is high, so we'll go with the first ultrasound, and if less than 1 centimeter, so follow up after 6 to 12 months, again with ultrasound. But if above 1 centimeter, so we'll go there with the fine needle aspiration. And if find it is cancer, so go surgery. If not sure, so go again with FNA aspiration. And this is our result of FNA cytology of our case, and we can see the feature in this cytology, and we can look here the nodule. It is look like normal, and here it's different. Okay, and if we go zoom in, try to find the feature in the cytology. The first we can find this finger-like projection papillae, and we can see here the fibrovascular core, and try to find the diagnostic feature. It is the nuclei, and it's we can see it is clear, it is empty, and show it is look like the ground glass, and also it is look like orphan and eye. It is back to the name of the cartoon, old cartoon, and this is the same eye of the character there. And yes, and also try to find, and also there is if we can look also for nuclei, we can find the nuclear grooving. Okay, nuclear grooving. And also if go zoom out, we can see here this dystrophic calcification, and this is back to samoma body. Just back to our presentation. So all this feature and the previous slide talk about the papillary carcinoma. So gross feature of papillary carcinoma. This is the normal, and this is show the single nodule, and we can see the multiple nodule, and also we can see single again, but it is infiltrative nature. And we can see again here this is the finger-like projection papillae, and this is the orphan and eye, and also the glass appearance of the nuclei, and also we can see the samoma body Basically it is dystrophic calcification. Papillary carcinoma, it's about 80% of the thyroid cancer, and the average patient age 30 to 50 years of age typically present with a large non-tender cervical lymph node that often palpate before the primary tumor because the early lymphatic spread, and as we look in the scenario in the ultrasound result, was a hyperechogenic picture region, and this likely represent microcalcification, which are typically for this cancer. Papillary carcinoma is the most likely diagnosis in the patient based on the overall incidence, affected age group, and metastatic patterns. And this my part, and my colleague Abdelaziz Asiri will complete the next.
Hello, I am Abdelaziz Al Ashiri, and I will talk about characteristic of thyroid cancer. In thyrocytes, there is papillary thyroid carcinoma and follicular thyroid carcinoma, which is well differentiated, and anaplastic thyroid carcinoma, which is poorly differentiated. And in parafollicular cells, there is medullary carcinoma, which is poorly differentiated. The characteristic of papillary thyroid carcinoma, which is our case, most common type of thyroid cancer, palpable lymph node due to metastatic spread, maybe multifocal, very good prognosis. Distribution: 8% of cases, peak of incidence 30 to 50 years of age. And follicular thyroid carcinoma characteristic: hematogenous metastatic, especially to lung, bone, rarely multifocal, vascular, and capsular invasion. Good prognosis. Distribution: 10% of cases, peak of incidence 40 to 60 year of age. And anaplastic thyroid carcinoma characteristic: rapid local growth, symptom of compression of the structures, lymphatic and hematogenous metastasis. Very good prognosis. Peak of distribution 1 to 2 of cases. Peak of incidence after 60 years of age. And medullary carcinoma characteristic: sometimes genetic predisposition, sporadic, produce calcitonin, diarrhea, and facial flushing. Distribution: 10% of cases, peak of incidence 50 to 60 years of age. That was my part, and my colleague Abdullah Sharani, he will take over.
Hello everyone, my name is Abdullah Sharani. I'm going to continue our presentation. For investigations, we start by thyroid functional test to determine which is the hyper or hypofunctioning thyroid. We can do autoantibody titers, determine which swelling is its manifestations for chronic lymphocytic thyroiditis. Ultrasound useful to determine the physical characteristic thyroid swelling, and the isotopic screen also determine the functional activity related to surrounding gland. Next, please. Final needle aspiration cytology has excellent patient compliance. It is simple and quick to perform and rarely repeated. Aimed at diagnosing colloid nodules with thyroiditis and papillary carcinoma, medullary carcinoma, anaplastic carcinoma, and the last not least, lymphoma. Final needle aspiration cytology cannot distinguish between follicular adenoma and the follicular carcinoma, as this distinction dependent not on the cytological but histological criteria, which include capsular and vascular invasion. Finally, the aspiration is less reliable in the cystic than solid swelling. We can also do other additional studies after confirm our diagnosis. For example, thyroid cancer tumor markers to see if there is follicular or papillary thyroid cancer, like thyroglobulin, because for thyroid hormones produce exclusively by thyroid gland, indicated after total thyroidectomy and ray therapy. Medullary carcinoma, like calcitonin, a hormone secreted by parafollicular cells, which is the tissue original for medullary carcinoma, which is supported diagnosis and determined response to therapy. Thank you very much. This is my part. Now my colleagues will continue.
Hello, everyone. My name is Abdulhamid Abdulrahman Fawzan. Today, I'm going to talk about the etiology. Genetic factors, medullary carcinoma associated with multiple endocrine neoplasma type 2, papillary carcinoma associated with RAT and VTC rearrangement and BRAF mutations, follicular carcinoma associated with BAX8 and BAR-Y rearrangement and RAS mutations, undifferentiated anaplastic carcinoma associated with TP53 mutations, ionizing radiation associated with papillary carcinoma. Next, please. Clinical feature. Thyroid nodule, firm to hard consistency, typically painless, feature of local infiltration or compression, recent onset of any of the three following: hoarseness of voice, and dyspnea and dysphagia. Next, please. The management. The management based upon result of fine needle aspirations. Suspicions for any malignancy, we go to through thyroidectomy. Our case talking about papillary thyroid cancer, go to thyroidectomy. If is it non-diagnostic, repeat using ultrasound guidance. If is it benign, like adenomatous nodule or macrofollicular pattern or colloids, or like Hashimoto thyroiditis, we go to repeat ultrasound in 6 to 18 months to assess stability. If it growth by more than 20% in 2 or 3 dimensions, consider repeat fine needle aspiration. And thank you for listening for our presentations. Thank you for all.